Afternoon. I realize that the groups are still drifting back into the auditorium, but for those of you who are back here on time, and given the nature of the session that we're going to hold right now, Dr. Dzau and I thought that we should just go ahead and get started. So for those of you who maybe weren't here this morning or haven't really focused on the agenda, what we're going to do right now for the next something like 45 minutes is to really have an open mic session to discuss ideas that people have for research that you feel needs to be undertaken in the short term, and that wasn't necessarily covered within the 4 topic areas that were selected for this workshop. And so, we've just had the 4 breakouts, and we will hear reports from those breakout sessions in about 40 or 45 minutes. But this is a time now for all of you to come to the microphone and speak. Just a reminder that this workshop will result in a report from the Institute of Medicine published by the National Academies Press. It will be made available publicly, and that the report will summarize what everybody has said here today, and including suggestions that come forth in this session, and that we're really looking for input that has to do with, in the short term, what kind of research ought to be considered. We're not going to be producing any kind of consensus or recommendations from this workshop, and we're certainly not at this point in time involved in any kind of after-action process of evaluating what's been done, how well it's been done, what could have or would have or should have been done to date, but rather what would be a good idea to do now and in the near future in terms of research to be able to sharpen our ability to respond to the Ebola outbreak, as well as future outbreaks that might be similar. With that, I'm going to move over to the desk and join Dr. Dzau, and the mics are open, and invite you to come to the mics.
So we have about 40 minutes while the rapporteurs are putting together a report back. This is a good opportunity for us to brainstorm, and on areas that we did not cover. As Lynn talked about, we talk a lot about, or at least we consider here, transmission, environmental factors, personal protective equipment, handling of infected material waste management, and so what other topics do you think we should be considering? It's not the focus of this workshop, but we certainly would be open to hear things that we should be considering for the future. Identify yourself in the microphone, please.
Thanks. Yes, hi, I'm Jeff Duchin from Public Health in Seattle, Washington, and in the University of Washington. So there are 2 issues that are on my mind, and I haven't had a lot of time to think through them thoroughly, but the issue of quarantine and effective strategies, research around, we have a variety, we have a whole menu of different quarantine options, that are currently recommended, and they're based on different risk assessments. And just perhaps knowing a little bit more about the effectiveness of the different strategies and the reliability of the information on which those risk assessments are based might be useful in the future. And then my second issue also, I'm not sure this requires research, but maybe risk communication. This is always big in any new emerging outbreak. And, just looking back, whether or not we could have done anything differently or not, based on available information, or is there new information that would have allowed us to do anything differently, or in the future, be able to get messages out that would be more well received.
Thank you.
Good afternoon. Jeremy Brown from the Office of Emergency Care Research at NIH. One of the things that struck me about many of the discussions about Ebola is the focus on the care of patients in whom the virus has been detected. And of course, the first case here in the US was seen, possibly missed in the emergency department, and then came back. There are a number of people who present to our hospitals saying, I almost certainly have Ebola, But in a real outbreak, which we fortunately have not seen yet, but in a real outbreak, that would not be the case. There would be people with undifferentiated symptoms coming to our hospitals. And I would really like to see research that is focused on how we care for the patient with undifferentiated symptoms that suggest but are certainly not conclusive of infection. This includes how we take care of staff who are in that situation. We don't expect all of our nursing staff in triage booths to be wearing personal protective equipment. But on the other hand, it is those nurses who are going to first see patients with these undifferentiated symptoms who only then, it turns out, may indeed have this virus detected. So I think there really needs to be a research agenda around preparedness for public health emergency responders and those in the emergency department. I'd also like to just again take a moment to pause when we think about the high-tech stuff that we like to do in the United States. Perhaps I can beg your indulgence. I used to work at George Washington Hospital. That's 6 blocks up the road. I started the HIV screening program in the emergency department there. And much of the discussion in public health screening for HIV was around the right way to do it in emergency departments. What it comes down to is, do we need extra staff, or can we include the staff who are already there? In many discussions I had with public health officials, the discussion was about getting the latest and greatest third-generation technology out to emergency departments that can detect the RNA virus within 2 weeks as opposed to 2 months. And I spent much of my time trying to convince people that it's not the high tech that we need, but it's the boots on the ground, getting the simple test to the patients. And that's where the lesion, at least for HIV screening in emergency departments, was. And I use that as a model to think about this again. It's all very well talking about the latest and greatest high-tech technologies that we have, but the real issue is going to be how we get those technologies, or perhaps ones that are slightly less special, down to the patients on the ground. And that's going to require some serious thought and research at the level of emergency departments and emergency responders. Thank you.
Thank you.
Thank you. I think the emphasis on emergency departments is excellent.
Yes, I'm Bill Cooper from the National Science Foundation, and first of all, it's been a fantastic day. And second of all, one of the things that we have the ability to do is to get rapid grants out the door. These are small funds that can go out the door within about a month. They're much different than the well, it's just like this meeting as opposed to having it go through the peer review here at the National Academy. It takes a long time for something to come out. Well, at any rate, one of the things that actually picking up on the risk communication, we're going to be funding a group of people up at Tufts to work out a couple of YouTube videos to inform people in the high school levels about Ebola. And that was reinforced the other day when I was in Panera Bread having dinner, and the couple next door to me, a young daughter and her mother, spent the entire dinner time talking about Ebola. So I think it's important that this communication at all levels goes out, because these kids, I tell you, I bet there's kids in the kindergarten that are talking about Ebola all the way up to high school and into college. And I think the more we can communicate the real facts about Ebola and try to get rid of some of the fear factor, I think it will do us really good.
Thank you.
I bet you enjoyed that eavesdropping. I did. Very good.
Yes.
Please.
Yeah, hello. My name is Charu, and I'm from the Association for Professionals in Infection Control and Epidemiology. And I fully understand what the remit of this workshop is, the US-based, and we have to identify research priorities that need to be reported, et cetera. But in my capacity, I would like to advocate for implementation research, because our members are the infection preventionists who are working on the front lines of this country, as well as those who are able to go overseas or going there. And what the kind of research they need is much more implementation-oriented, which is not to diminish anything, any of the topics that have been identified for more basic or translational research, but to just bring to the forefront that there is really a lot to be learned from the situation in West Africa, that there are a lot of professionals right there, even from this country right now, and it would be so useful to have a mechanism in place to somehow collect their experiential wisdom, experience, their empirical, what they've gone through, to collect, even if they are we're not talking about RCTs and we're not talking about even prospective studies, we're just talking about what did they do to make things happen. And that's not to say that we have to adopt them, but we can look at them, to study them, to see what is viable and what is not. Dr. Fair, in one of the sessions I was in, said that, or maybe he wrote that somewhere that I read, that still the most important thing is to contain the virus. And, that's taking us back to the origin of it. Thank you.
Thank you, appreciate it. I think there's agreement there because we talked about health system strengthening and the need to know how to actually take care of these patients, but getting the evidence for how to do this is the critical issue. Please.
Good afternoon. I'm Lynn Hardy from the National Institute of Nursing Research at NIH. I feel like I'm almost preaching to the choir after listening to a couple of the people who have already posed questions. But I think communication is a very important issue, and multi-level communication, so that we have a consistent, accurate, and non-punitive communication system to really let the public know what's going on. And secondly, as we talk about the research issues that from the 4 main areas, I would encourage the use of data standards and data sharing so that we can aggregate the information that we gather in a consistent and appropriate manner so that we can maximize the data that we do capture.
Thank you.
Yes.
Hi, this is Martin Sepulveda. I'm from the T.J. Watson Laboratory at the IBM company. I want to make 2 comments. One is I want to echo one of the other commentators' strong recommendation on this research has to be simple, fast, and cheap so that it can get out into where it needs to be and become part of a workflow and not be like so many other technologies that come into clinical environments and disrupt workflows. Mm-hmm. The second is that we have the opportunity to be able to incent and fund research that creates transparency around protocols and that creates requirements for standardization of data sets and data formats. This allows for the aggregation of these data to be made publicly available so that they can be utilized by others, both researchers and entrepreneurs, for innovation in many of the areas that this infectious disease is challenging us with.
Thank you.
Thank you.
I'm David Lipton, and I'm with the North Carolina Division of Public Health. I'd like to talk about, or I'd like to see more work on health risk communication, but I'd like to see it more towards healthcare providers, private practice healthcare practices. I'd also like to see law enforcement, wastewater treatment operators, emergency responders at county and local levels. I have 2 concerns. One's already been addressed. That's the issue of options for isolating people who have either returned from Africa or suspected of having the disease. But I also have a concern about on the back end. If you look at what happened to Mr. Duncan's apartment, which essentially everything was burned and destroyed, I think that was a crime because that was basically taking away his property without due process and without science-based. And I don't think that would go over very well if it was somebody that had a little more authority or was more media savvy. And we really don't need bad publicity like that anymore, and there's always options. And I would like that, the idea that there's always options out there to be communicated down the line to find solutions that people can more or less accept.
Thank you. And if I may there are some classic issues here that come up again and again in public health, the conflict between civil liberties and public health protection that, you face every time there's an issue of a quarantine or imposing vaccine requirements and, many other measures that, that occur. And the issue, I think, of due process and that's come up with the nurse who did not want to be quarantined. It's come up in the issue of the Dallas apartment, as you point out. And I think that it is also an area for research. It's a researchable public policy issue, actually.
Point. Thank you.
Bob.
Bob Harrison, California Department of Public Health. Another topic which hasn't come up thus far is whether looking at our public health workforce and our preparedness to respond to Ebola in the United States. Before 2 or 3 weeks ago, I was investigating, a case of a Hispanic construction laborer who fell off a roof in California, and I'm the same person that's, helping develop the Ebola response guidelines. We have a very robust preparedness funding and system in the United States, so I personally probably wouldn't be here being able to work on this if it wasn't for that capacity that has developed over the years. And I know that's the case with all my colleagues as far as responding to Ebola. When this blows over, we'll be, hopefully it will, but we'll be responding to the next epidemic or pandemic or move on to something else. Mm-hmm. And I don't know whether that relates at all to the topic here, but it just occurred to me that at some point looking at federal, state, local support for preparedness, making sure that funding remains robust and that we're all in place.
So, Bob, I think that you're right, and I think that there's a lot of interest that I've heard throughout the day in this whole issue of health system capacity, public health system capacity to respond to this, and not only domestically but also globally, the global capacity, and the elements being not only the capacity to respond but also the capacity to respond in real time, and the degree to which we could be ready to go forward more quickly with responses.
I think it's very clear to me in today's discussion, while we're talking about U.S. preparedness and response, it is a much bigger issue globally. And I know that Assistant Secretary who's here has asked us to think about this in that context, but it's very clear as well that she and others are thinking, along with people beyond U.S., how to have a global security framework that has those kind of pieces in place so it can respond to any of these new emerging challenges. Thank you. And certainly, you say funding is one of them. No question about that. Yes.
I'm Deborah Sharp. I'm representing the American Biological Safety Association, and I want to thank you and the rest of the organization here for inviting us, because it's been a real struggle for me personally and for biosafety professionals and for biorisk management professionals during this whole process. We have been dealing with managing infectious agents in high containment laboratories over the last 30 years in BSL-3 and BSL-4 laboratories, where we work with infected animals, infected with risk group 3 and 4 organisms. We understand the issues about protecting our staff, how to don and doff PPE, how to make sure that there is no spread of infection outside of containment. And I was also part of the team with the Elizabeth Griffin Foundation that was in Nigeria, in Port Harcourt, and we trained over 800 healthcare workers to respond before they had their first cases. And as a result of the training that we did there, we had over 80 volunteers volunteering to work at the Ebola treatment centers because they felt confident in wearing their PPE. I mean, we had them all don and doff. We used glow germ. We showed them their mistakes. And we also had to train the ambulance drivers, and we trained the morgue owners on how to manage cases. So, and we also had the ear of the ministries of health. And I think it was in no small part, something that we can be very, very pleased about, that Nigeria got a handle on that issue. But it was very disappointing to come back to the United States and find out that, every week the recommendations coming from CDC were changing. We would have recommended the appropriate PPE the first time had individuals at CDC reached out to the biosafety professionals and ABSA and asked for our input. Even though we were trying to provide it, it wasn't very well received. And it was just very, very frustrating to those of us that are in this field that we are not, being asked or had not been asked to provide input on that process.
Thank you.
Hi, I'm Bonnie Rogers. I'm at the University of North Carolina. And I think I haven't heard much discussion about ethical issues that relate to these kinds of exposures. And many of those issues relate to acceptable risk, particularly for the healthcare worker, confidentiality not only of the patient, but the healthcare worker. I'm just surprised at the enormous amount of information that's been in the media, not only about the patient, but about the healthcare workers. And perhaps they have given permission to do that. I don't know that answer. But there are many of those ethical issues that really need to be paid attention to. And part of the reason for that is that when we do science, it really are the ethical issues that come after instead of before or concurrently, and then we're stuck. And those kinds of things are really paramount. I've been in some meetings where the discussion is the healthcare worker should accept any risk that comes along the pike, rather than not even giving any consideration to personal protection or how that person can be protected. And should there be situations where healthcare workers who are already at risk, what do you do with those people when they're immunocompromised? Should they be told that they still have to do this? What are the important parameters when someone is taking care of an Ebola patient and taking care of other patients as well? So all of those factors need to be considered while we're looking at Ebola now, not after the fact. Thank you.
Thank you.
This is Somsandran from Columbia University. You are very right. It's a global problem. And in regard to that, there is United Nations, World Health Organization, as well as other countries looking at this problem. I don't know whether Institute of Medicine has. I'm in the National Academy. I know we have Federation of National Academies. Is there any effort to look at what other countries are doing, WHO, United Nations, and coordinate the effects so that we don't all invent the same wheel or different type of wheels?
Thank you. And we're well aware of that, and we are having conversations on that particular issue.
I mean, another thing that could be done is to look at other kinds of issues that are handled on a multinational basis outside of the health arena to see if there are more effective mechanisms that have been developed in other sectors that perhaps could be adopted. Because I do think that the tradition in the health sector has been that when we do multinational work, that we do many, many, many meetings and before we reach a decision about what to do, and we don't have response mechanisms that allow us to trigger immediate action. There aren't mechanisms that have been agreed upon where, something happens and bang, the world goes in together to act. But perhaps there are other sectors where that kind of mechanism has been worked out. I don't know.
Yeah, I think earlier on, both of you raised really important issue about how do we emerge from all this experience a better place globally in U.S., and I think we're well aware of that opportunity. Yes.
Hi, my name is Ty Duggins. I represent Cornerstone Environmental Technologies Incorporated. My question centers around the African diaspora that's located here and in other parts of the world. And how do we engage that group of individuals to become more proactive in this process? I'm personally aware of doctors, nurses, epidemiologists, parasitologists, microbiologists, and they exist throughout this country, but I think there's no active network that's been developed that they can plug into so that they can bring their expertise to bear, particularly in countries like Sierra Leone, Guinea, where English isn't necessarily the primary language, and you can bring these people into that process where they have a cultural understanding. Even if we're bringing technologies that work, there may be some pushback by the natives. So we need them to be able to communicate that message and keep the narrative, I guess, non-threatening, but they can certainly walk us into that space and allow workers to come and people to come in and to help in that scenario. Is there a way for that group? Right now I'm working with a group that's plugging into USAID, the State Department, and World Bank, but could they plug into your organization as well?
That's a good point. Thank you.
Penny Hitchcock. I'm pleased to follow the gentleman's comments because I know that we are here mainly to talk about medical research. However, it takes a village. And I think that the education of our school nurses, our teachers, our clergy, people who provide support, who have to go in and help people cope with the idea of being quarantined or the loss of people or the fear of loss of people. Too often, and we do, I obviously 20 years in the National Institutes of Health, I get what we do for a living in terms of the science, but the interface that comes with behavior and understanding and working together in a productive way, many of the things that you're going to codify here can be adopted and understood and make the community a more functional place. Thank you.
Thank you.
For the next comment, I wanted to mention one thing and to see if people in the audience had ideas about this. I got a phone call late last week from a very informed colleague, public health colleague, who asked why weren't we discussing methods for doing rapid monitoring of people in travel, such as temperature monitoring, and the validity of different ways of doing that. Why weren't we, why wasn't that a topic? And so I just wanted to mention that to see if some of you in the room may know more about that. Perhaps there is research underway on that, and or maybe that is an area that needs more work. So.
Hi, excuse me, Andy Levinson from OSHA. One of the topics that's obviously been in the news quite a bit has been the efficacy or necessity of travel bans in controlling Ebola. Both internationally as well as domestically, there's been efforts to limit importation of medical waste into certain states. Mm-hmm. And so, I think that's certainly an issue that the Institute could weigh in on.
Thank you.
Julia Gunn, Boston Public Health. A systematic evaluation of the airport screening program and the subsequent follow-up that is now required by state and local health departments, including a cost-effective analysis, would be most helpful. We may be able to do this for these 3 countries where the travel is not as extensive as, say, for example, if it was China or Vietnam. And that would pose many challenges for public health. And to know that this is a viable option or doesn't work at all will be very helpful in planning for the future.
Okay.
Appreciate those comments. That's excellent.
There are additional ideas, suggestions, comments, issues that you wish the workshop had brought forward or would like to see another workshop bring forward in the future?
Please.
You compelled me to get up, so.
Yeah.
John Lowe, I'm with the Nebraska Biocontainment Unit. I just wanted to point out, so over the past weeks, I know Emory and us and NIH have really been overwhelmed with requests for information, and a lot of those have been focused on gaps between guidance and practice. And I know that a lot of what we're here to discuss today is to try to shore up those gaps. But I feel that we would be remiss if we didn't identify that what we're starting to see now, and we're probably on the precipice of, is this massive expansion in these high-level isolation units. So our group was on the call last week with a hospital in New York that is in the process of ordering a standalone clinical biocontainment unit. And in the process of that call, where they just wanted us to really look over the blueprints and start to, rationalize and think through what types of things they may have missed, the vendor was also on the call redrafting the blueprints while we were talking through it. And they indicated that they have, they're expecting a legitimate 20 orders of these units from U.S. institutions. We've also been in regular conversations with other institutions and universities that are starting to remodel existing facilities. So the point that I want to make is I think that this calls for some sort of coordinated national strategy for developing these clinical units for highly infectious disease. Our European partners, which we modeled a lot of what we have done off of, the UNID or EuroNID group, they've kind of revised their names. But so they did this in the late 90s, early 2000s. They developed really sound protocols for transporting, for PPE, and these really end up being the perfect environment to do a lot of the research that we're here today asking that needs to be done. So I just think that we need to keep that in mind, that as the capacity of high-level isolation explodes in the U.S. in the coming years, that we think about a coordinated approach to align that with the research questions that we're identifying here today.
Okay.
I appreciate that, and I think it fits nicely into the conversation earlier about emergency departments and how you, in fact, have first response, how you handle this, and then have a more coordinated way. Fits nicely in the conversation of supply chain, in terms of every hospital trying to outfit all that stuff, where you really could have coordinated response in more specialized areas. Thank you.
Hi, Dan Hanfling on the Planning Committee. So actually following up on that comment, I think that we need to look at the economic implications of planning and preparedness going forward, and looking at it in the context of a variety of scenarios, and really what that is going to mean with regards to the sustainability of response, and where we can best apply health systems, preparedness and retooling to get the best and the most out of what will be a scarce resource and certainly a short dollar. So,
absolutely right.
This is Jeff Dugan again, Public Health, Seattle, Washington, University of Washington. I wanted to follow up on the same thread. The whole issue of integration of the private healthcare system and the public health system in responding to bioemergencies, emerging infections, natural disasters, and so on. I mean, it's an area that's certainly been very important and a topic of much consideration, but when these events happen, there are always many, many issues that are unresolved at the time, many challenges, and I think additional research on ways to improve that integration, and particularly in the context of Ebola, the concept of regionalization of care of highly complex cases. Initially the message was every hospital needs to be prepared, and then we thought about that a little bit harder and said maybe that's not the right way to go. So understanding what capacities and capabilities are out in the private sector and how those can be best used in the context of public health emergency response would be very valuable to do before these events happen.
Great comment. Thank you.
I mean, if you may, I think that there's a potential for some kind of systems approach to looking at not only the connectivity between public health and the private healthcare system, but also the entire web of support that's needed in terms of linking, care to, for example, waste management and incineration, and connecting up the policies that the different states are rolling out. I've spent a lot of time trying to explain to reporters the fact that this is not covered under the Interstate Commerce Clause, because if it were contaminated food doing this and it were in commerce, then it would be a federal issue, but that the states have these individual police powers, and they're making very different decisions about how to implement them. And if we really had a much larger epidemic, this would become an enormous problem. And I don't know, I'm looking at Nikki Lurie right now, but, I don't know if there's, at the end of the day, issues that would even be needed to address legislatively, but certainly the coordination opportunities are there, even without that.
David Goldman with the USDA. This is a little bit of a field of our discussion today where it's been focused on person-to-person transmission, but I do wonder if there's any work at all going on in the region in West Africa to look at the role of domesticated swine there in terms of ongoing transmission. We know that swine can be effective reservoirs and potential vectors for the virus, and I think we should try to take advantage of any work that could be done there in the field, wildlife biologists perhaps, to look at this possibility.
Thank you.
There is an ecologist here who's with Rocky Mountain, and I asked him about just the ecology of the virus as it exists in West Africa, and there's still a lot that we just don't even know about what the actual reservoir for the virus is. And there had been research on this, but he pointed out to me this is extremely difficult research to do. But it would be nice to know how it actually exists in the wild as it's being introduced by humans into new environments.
Hi, Rich Serino, currently at Harvard School of Public Health National Preparedness Leadership Initiative. Until a few months ago, I was the deputy administrator at FEMA. Worked with Nikki once or twice. A couple of things that I think may be worth looking at from a research point of view is sort of a theme that I heard throughout the morning in some of the sessions was specifically around communications and risk communications. It was pretty much a theme that went through a lot of things, and some of the quotes that people had were, I'm just not sure how we're going to do that. That's somebody else's problem. It's an issue. Pretty consistent quotes that happen throughout the day. So, but I think not just risk communications, but how that connects to what we saw with the fear from people and the psychological aspects of the fear of poor risk communications and how that ties together and looking at the linkages of those and how that in itself linked towards leadership and how leadership fed communications or fed or didn't feed the fear that it created that fed and caused, looked at the organizational structure. But I think looking at the research of that and how that affects would be something worthwhile. Thanks.
Thank you.